that you have for Parkinson's disease, the Michael Fox Foundation. And once you get a foundation and get a movement going, you start to see progress, you start to see change. And certainly his foundation has really pushed the country to move into, and medicine to start around the world to look at Parkinson's disease and start to make some advances. You know, long way to go still, but it's happening. And I think of all the medical specialties, neurology, I think, has been one of the slowest. Looking at the nervous system has been one of the slowest things to see significant advances happen through my career in medicine. I know talking to a neurosurgeon when I started anesthesia, I said, so, you know, what do you do for this brain tumor? And he said, well, basically we just light a candle and say prayers. Because there wasn't a lot they could really do. When you look at depression, a very common illness in the population, what was sort of the final treatment? It was electric convulsive therapy. And I don't know if you've ever seen that, but they put these electrodes on your skull and they give you an electric shock. And to me, that's the equivalent of hitting you on the head with a baseball bat. In other words, that's where the therapy has got to. That obviously shook up the brain, and some people did a little better because of it, and it helped them. And so it continued. I think it still continues to date in some cases, but it's not science. It's not what needs to be done in terms of, is it a cure for cancer? Is it a cure for depression? You know, cancer's gone a long way because there's been a tremendous drive to focus on cancer therapies, cancer treatment. Not so with neurosystem, the nervous system. And I think the Michael Fox Foundation has done a lot to start to move things in the right direction. And that's what I think foundations do. As I'm involved in patient safety now, and we're trying to get a movement going that will reduce the preventable harm that takes place in the healthcare system. And we don't know the actual number of harms that take place in the healthcare system, but looking at areas where the payer is the government, we can look at some of it. And the estimate is probably around 200 to 300,000 preventable deaths a year in the US in the healthcare system. In other words, these are patients who not only were harmed, but died as a result of medical care. And so, and we don't talk about it, we don't publish it. So that's what my foundation is trying to do, is to get the real numbers. And finally, with electronic records, we're starting to be able to use artificial intelligence to look at these records and start to pick up, and we're starting to get a handle on some of these numbers now and really beginning to get some data. And once you get data, people react to data. You can start now to see improvement, you can start to see change. And that's what I think Michael Fox has got going with Parkinson's disease. I mean, we certainly do know the number in this country, or a good estimate of the number of people. Over 1 million people have Parkinson's disease in this country that's been diagnosed. And there's probably more who've not been diagnosed because of the healthcare system. But there's a lot more that can be done in healthcare, a lot more needs to be done, and this is a focus area which I think a tremendous amount can be done. And I think, as I say, the Michael Fox Foundation have done a good start on it. He's driving force. He's got the attention of a lot of leadership in the country and around the world. And so he's got a lot of support coming in, and that's going to make a difference. But I think what I was really asked to come talk about was, what happens if you have to come into hospital and you need surgery and anesthesia. And I think, first of all, just listening to what you were saying, if any of you, whether you've got Parkinson's disease or not, if any of you come into the healthcare system, have a trusted friend with you. You need what we call a wingman with you that can listen and knows you and you trust, because they can listen to the information that's been imparted. If you go in as a patient, and I went in 2 years ago and had some major surgery, and I knew the surgery backwards. I knew the surgeons backwards. I knew everybody backwards, you know. But afterwards, I'm starting saying to my wife, what was I supposed to be doing? What have I got to take? What were the instructions? And when you're a little bit stressed, and it's you're not listening, you're just there, you don't get all the information, and that's why, and you don't impart all the information either. And that's why it's really important, if you can, get somebody you trust, hopefully your spouse or whatever, your loved one, to go with you, to be your wingman, and talk about what your symptoms really are, what is really going to go on, and ask the questions, you know, and note down, have a note paper with you, and write down what the instructions are, because clinicians like me, you know, we've done it so many times, we've told so many times, it's automatic. We just assume you understood what we were saying because we've said it 500 times, 5,000 times, and it's you, and for you it's one time. And we have to slow down and really spend the time with you and really understand that you understood what we were imparting to you. Yes?
I want to ask you a question. Let's say I had to go to a hospital and my spouse was coming with me. Wouldn't it be a better idea, possibly, before we go, to have a list of questions we already have together?
Absolutely, yeah. And there is actually a little app you can get called a patient aider that has got some of this information on it. We've just got involved with it recently. It needs to be updated and improved, and that there's too much information on it. But there's clear things like that that you ought to do.
What is the app called, Doctor?
Patient aider, P-A-T-I-E, patient and then A-I-D-E-R.
A-I-D-E-R, it's an app.
It needs to be improved, and that's what we're working on
Okay.
right now, because we've got involved with it. No, you're absolutely right. Bring pen and paper, bring questions, and write down the information you're being told, or have the person you bring with you do that, because you won't remember it in all likelihood. And I think with Parkinson's disease, going into a hospital, everybody's heard of Parkinson's disease. If you go into a major medical center, they'll know a lot more about it. If you're going somewhere to have a deep brain stimulator put in, clearly they've got experts there in the disease, and the team that's going to take care of you, if that's what you're going to go in for, know intimately all about that illness. You go into a surgery center, they all know the name. Sure, we know Parkinson's disease, we even know Michael Fox has got it. But other than the fact that you're a little bit stiff, a little bit shaky, they don't know much more than that, particularly with things that are most important. And one is the medication you're on. The first thing they'll tell you before you go in to have surgery and anesthesia is nothing to eat or drink after midnight. That has changed in healthcare probably 10 years ago, where we suddenly realized for most people that's not necessary. For many people, we start this what's called enhanced recovery program, where we actually give them fluids an hour before surgery, and they get Ensure or something like that, and they do better. It's vitally important to you that you continue on your medication, that it's not stopped. And yet I will guarantee you that most surgery centers that you'll go into, somebody will tell you, maybe not your clinicians. They may say you can drink and take your medication, please do, but somebody in that line will say to you, absolutely nothing to eat or drink after midnight. It's called NPO after midnight. It still occurs down at Baylor, despite the fact that we've had 10 years of this now, where we've, except for, there are some exceptions to this, but in general, unless we actually give it in writing to the patient or give them the fluid to drink, as we do in many cases, somebody will stop them at some point and say, you can't. For you with Parkinson's disease, it's actually vitally important that you can, if you're on levodopa or if you're on one of the medications, that you stay on it. Because you need that medication, you need to get that dopamine replacement. If you don't get it, your symptoms are going to get worse. You're going to be more unstable after surgery. So we want you to keep on it through the surgery. Even if it's a long surgery, we've got to look at ways that we can give you the medication during the surgery. So that's probably the number one thing. And I'll slow down a little bit because I want you to ask questions if I'm saying something.
Would it be okay? Because we had, Pat had a question regarding anesthesia, and I think probably it's a good time.
Yeah.
I was asked by a Parkinson's individual who could not be here today to relate his story to you. And my husband shares with, Mike is his name, a similar story. And to begin with, my husband Bob, he had an emergency surgery about 4 years ago, something like that, maybe 5. Yeah, and it occurred on a Friday night, and so I was in the waiting room in the hospital, the only person in there, because it's a Friday night, and I didn't get called, and I finally went to the nurse's station, and she made a call, and she said, they want you to follow me to the recovery room. And this is hours after his procedure. And I went into the recovery room, and every time I say this, there were 2 security guards from the hospital holding him down. And there were nurses around him, the anesthesiologist was still there. It's now like 1 o'clock in the morning on a Friday night. And he just wanted to jump off the table. He wanted to go to the bath. You know,
The whole thing was that I wanted to go to the men's room.
After major, and so they had me continue to talk to him, saying that a loved one can sometimes bring the temperature down. And eventually he got into the recovery room, and then I stayed with him and I spent the night, but it went on and on. Mike, the gentleman who's not here, also he had actually knee replacement surgery. And neither one of them had any Parkinson's symptoms prior to that. And prior to the surgery. And in Mike's case, they say, without going into his long story, that it took him 3 years to really fully recover from it. And right after the surgery, for the very first time, his symptoms began. And I would say, similarly, Bob's did as well, shortly thereafter, just a small tremor, and he's never had any major tremors. It's just a small one, and it has stayed that way. Nevertheless, the question is it possible for anesthesia to bring out something, or bring it to the surface, or affect someone the way both of these gentlemen were affected?
That's a $1 million question. It really is. There's a lot of animal data showing that if we give anesthetics to a neonate, like a small baby animal, the brain development is hurt. There's some data looking at young babies having multiple anesthetics, that the brain development gets hurt. The bigger studies coming out now show that that's probably not true, but we weren't monitoring brains in the past. Now we actually have some fairly sophisticated brain monitoring, and certainly you wouldn't get it in an outpatient surgery center, but in a big hospital, you could probably get it. Certainly we have it down in Baylor. And we can look at the brain under anesthesia. And the same amount of anesthetic can really affect the brain differently in different people. When I, for instance, if you look at somebody my age now, and you put a brain monitor on, and you go under anesthesia, you see a very different trace than somebody of 20 years old. The 20-year-old brain is much more active, there's much more power in that brain, much more activity in the brain. When you get a little older like me, you can actually see that power in the brain has gone down some. It's not the same as the 20-year-old brain. When you have an anesthetic and you have the right level of anesthesia, you would think the brain would just go quiet and you're asleep, therefore the brain's doing nothing. In point of fact, if you're at the right level of anesthesia, the brain is very powerful under anesthetic, and you can see this power. What has happened is the circuits have got disconnected, but there's a tremendous amount of power in the brain at the right level of anesthesia. If I take you deeper, that power goes away. If I take you very deep, there's no power in the brain at all. And the likelihood that you will recover back right away to your normal mental acuity that you had before you had that anesthetic, in some people doesn't happen. It takes time. I mean, you probably, just like your story, I had a lady who lives about 5 doors down from me and said she had to have a total knee replacement. And she was the top bridge player in the neighborhood. She'd win all the bridge tournaments, and after the surgery, she couldn't play bridge. And it took her 6 months before she could get back to it. And so there's more and more data showing that if we as anesthesiologists take you to the right level and not further, that you recover better and you do better. That's not golden in terms of has it been 1,000% proven? No. But there's a lot of good information now putting it in that direction. The other thing is when you monitor the brain, you find out that some 80-year-olds have the equivalent brain of a 20-year-old. And some 20-year-olds have the brain activity of an 80-year-old. And so everybody's brain is a little bit different. And now we started got tools to monitor it. We're learning so much more different things. Why has the 20-year-old got a brain activity that's equivalent of an average 80-year-old? Well, was it lifestyle? Was it genetic? Was it, what was the reason? And until we monitor more people, we won't know the answer to that. But it does mean that we can now actually control the depth of anesthesia very accurately by using these very cheap monitors, but they're very sophisticated. You just put little stickers on the forehead and you can see what's going on in probably the most vulnerable part of the brain. It's something that we're learning an awful lot from. It's not standard of practice yet, but boy, if you've got to have major surgery and you're going into a hospital, I would ask for it. Because more and more of them now are going that way, and
What exactly would you ask?
a brain monitor.
That's it.
Just call it a brain monitor. That's probably the easiest thing. Yeah.
Is this something that the anesthesiologist is actually monitoring?
Yes. Yeah. And when we put them in downtown about 10 years ago, and it was interesting when we first did it, how many people, with all the clinical signs you could have of depth of anesthesia, when you walk into the room, I'd look at the monitor and I'd say, why is this patient in what we call burst suppression? Burst suppression means you're way too deep. There's very little brain activity going on. You run the risk of delirium when you wake up, you run the risk of memory loss, things like that, which, and again, it's not solid proven, it's still early work, but boy, more and more papers are coming out showing that this is the outcome. And if you can keep somebody, and it makes sense too, that if you keep a brain at the right activity level, but the patient's asleep, they're not feeling anything, they're not aware, they do much better. They wake up, like I can tell the second patient's gonna wake up just by watching the monitor. And you can have them awake on the table, almost not needing recovery room. So that there's some things that we can do that are beginning to help and make it, I think, making it safer. But the most important thing, going back to Parkinson's disease, is please stay on the medication. Talk to them, you need the medication you're on. If you come off it, your symptoms are going to increase when you wake up. You may have a more prolonged recovery period in the hospital that wasn't necessary. Because those dopaminergic medications keep your symptoms under control, and they're good for you, and they shouldn't be stopped. And so if there's some way you can take it by mouth because of the surgery that's going on, is there a transdermal approach? Is there another approach that you can use? And there are for those medications. So, but in all probability, unless you go into a big center, you're probably going to have to discuss this with, it'd probably be the surgeon if you're going in for surgery, but you need to discuss it with your clinician, make sure the information is going to where you're going to have the surgery. Because, if you're going to have a total knee done, that surgeon knows your knee joint backwards. He knows how to do the right approach. He can do it in an hour. He knows exactly every move he's going to make. But does he know much about Parkinson's disease? The answer is he knows of it, but he probably doesn't know the details of it. And what medication should you stay on? What medication shouldn't you be taking? Anesthesiologists, absolutely. There's some medications we use for, say, to prevent emesis, nausea, vomiting, that actually block the effect of your dopaminergic drugs that are helping you. And so they can precipitate an increase in symptoms when you wake up. So again, either you or if you can bring somebody with you who's got sort of made a list, which is a great idea, have on it, my medications. You probably don't know the medications you shouldn't take, but at least have put a question in there, what medications can I not have in hospital? And a simple one is like anti-nausea is Phenergan. Phenergan is a phenothiazine, and it is an anti-dopaminergic drug. That's how it acts, and that's a very common one used to prevent nausea and vomiting after anesthesia. And it actually will block the effect of the drugs you're taking. So, average anesthesiologist doesn't know that until he's been alerted or she's been alerted ahead of time. This patient's coming in has got Parkinson's disease. Then in literally 10 minutes, he's gone online, he's updated himself, he's reminded himself about drugs you can take, drugs you can't, what are the complications I expect to see during surgery, so I'm ready, I can react to them, I know what to do, and afterwards. The incidence of delirium is higher afterwards, and things like that. So we can avoid drugs that might precipitate that and be looking for it in recovery so that we can react to it if we see it occurring. So I think communication is where you really can help yourselves the most. You know, you go into a big center, they should know, and you should be sure that everybody there, but again, even in a big center, just make sure that you've told them you've got Parkinson's disease before the surgery, so that they can just be aware, to be looking for things that can occur during surgery and after surgery, and make sure they don't use medications that could interfere, and make sure that you're taking your medication when you come in. We want you to have the medication. Please take it on time, the usual time. Don't be putting yourself nothing after midnight. That's gone. You don't need to do that anymore. And I'm talking medication, I'm not talking food. We don't want you to have solid food, and that's what they'll tell you, but because it's been the standard practice for 50 years, somebody will tell you when you meet, or give you a phone call, just make sure you don't have anything by mouth after midnight. I almost guarantee you somebody will do that. And it's just not the standard anymore. We want you to take your medication, particularly with Parkinson's disease, and we want you to have some fluids, and they'll tell you, depending on the surgery, what the time frame is for the fluids. But certainly, most major surgeries now, we're getting you to have some sugar water or some Ensure or something like that up to an hour before surgery. In fact, sometimes we give it to you in the pre-op area, and it's gone out of your stomach by the time you come into the operating room. Other questions? Sorry, I'm talking too much
No,
again.
I'm glad you are, because now that you're here, anybody who has had surgery experiences coming out of anesthetic that you can relate to what Dr. Ramsay is saying.
Only the delirium that you had, bring that on.
Did you call it burst suppression?
Yeah, but burst suppression is, if you look at your EEG, that's the electrical activity of your brain on the monitor, where you can see all these squiggly lines. When you go beyond a certain point and get deep enough, suddenly you'll get a straight line, no activity, and then a burst of activity, and then a straight line. And if I take you even deeper, you just get a straight line. What we call isoelectric. There's no, and the amount of drug I give you might do it, and the amount of drug I give you might not do it. Everybody's different. So it's not a dose-dependent effect, it's how that drug affects you dependent effect. And so I can give everybody the same amount of drug and have a different outcome depending on your own, keep you on a very narrow course of being at the right level, not too light, not too deep, but that brain's very active, and I know I can then, as soon as that last bandage is on, you're awake, you're talking, you're back with us. And it improves your recovery, you get out of recovery room earlier. It's something that we can do easily, yeah.
But there's no specific anesthesia that you relate to problems with Parkinson's. It depends more on the individuals.
It does. There's one or two drugs related to anesthesia, like Demerol is a bad drug if you've got Parkinson's disease.
What's it?
Demerol is a painkiller. Yeah, you don't want to have that. It'll reverse some of the action of your anti-Parkinson drug. Phenergan was another one. Otherwise, it's more. Tramadol's another one. Yeah, absolutely. Tramadol's another one.
Tramadol.
Is that good or bad?
No, bad.
Bad.
Yeah.
And the other one is the anti-nausea.
Yeah.
I actually, I have a little cheat sheet here. I could actually make copies of it and give it to you to give to everyone if you like, or send it to you electronically.
That'd be wonderful.
Yeah.
That'd be good.
Yeah.
Okay.
Yeah.
Yeah.
But I think the best thing is communication. If you can alert the caregivers ahead of time and just make sure they understand, and probably if your family physician is referring you in, make sure that he's passing that information on to who he's referring you to. If it's a surgeon, make sure he understands that you've got that, so that, and maybe tell him, make sure the anesthesiologist knows. Because the anesthesiologist is basically going to control the medications just through that perioperative period, at least that day of surgery, and make sure they're alerted, because then they also know what to look for, because you're more sensitive when you undergo surgery, because the movement's not quite the same. We don't want you to get pressure ulcers or things like that. So the anesthesiologist can make sure that in recovery they're moving you, that moving you from side to side. We know the potential problems and how to treat them if things get out of line. Sometimes your airway can be more difficult because you've got some stiffness and that your neck doesn't extend quite as much, or your mouth doesn't open as wide. Again, all those things your anesthesiologist, your anesthesia provider will know once they're alerted to the fact that you've got Parkinson's disease, the next patient coming in has got Parkinson's disease. If they don't know, and they only discover it when they've got you on the table, already they could have used something they shouldn't have used. That's not the best for you. It's better if we can get that communication to the deep brain stimulators. That's really important to know. And now if you're going in to have one, that team knows all about Parkinson's disease, so that anesthesiologist will know what to do. Some surgeons like that done awake, some prefer it asleep. The team needs to know, but they do know. They're very, so go ahead. They know what works best for them and for the patient when they're doing that procedure. But if you're going in to have a hip replaced, or you're going in to have an appendix or something like that, or a bowel surgery, just make sure they know ahead of time, so that everybody in that OR is up to speed and they've refreshed their minds about the illness and things they can do, things they can't do. Plus they also know what to be looking out for, both during the surgery and early after surgery.
This is true.
Yeah.
This is true for, like, if you're going in for a test, like a colonoscopy or whatever, so what you're saying, the same level of...
Colonoscopy, although that's under sedation, they probably will tell you nothing after midnight. So I would make sure they know that you're taking Parkinson drugs and that you need to stay on them. Because those won't affect the colonoscopy. Not taking them may well affect the overall management of the colonoscopy.
I just wanted to know for testing, you mentioned, a lot of major surgeries, but when you're just going in for a regular, for a test, you still need to have that same level of awareness, communication with the anesthesiologist and so forth.
I think if you're going to go through for an anesthetic, for any procedure, you want to let them know that you've got Parkinson's disease and you're taking the medication.
Okay.
And hopefully they'll call you the night before so they can be alerted, so they can tell you to stay on the medication.
There is a difference, doctor, correct me, the anesthesia that they use for colonoscopy is not general anesthetic.
Well, honestly, it's 50-50. It depends on the patient. Yeah. It's the commonest drug used is propofol, and some patients say, I want to be out. A lot of patients say, I want to be out. Now in Europe, nobody gets anything basically. It's very little sedation, but the culture here is you get propofol or a little Versed, something like that.
Through an ID.
Yes, and so I would say that most people having a colonoscopy are certainly for the first part of the procedure are probably on what I would say would be under anesthesia, and then they're probably coming out of it as they're taking the scope out.
I
So,
have
yeah.
another question and observation. I've had a couple of surgeries on my back,
Yeah,
and I've had interviews with the anesthesiologist the night before, or the 2 nights before, going, and is that customary practice? I mean,
should be, yes. Unfortunately now with so many scam calls coming through, you know, we used to always call people on a cell phone in the evening. If you don't use a hospital phone now, so it comes up on the on your ID as a hospital, a lot of people won't answer the phone anymore. And then you're a little bit nervous about what kind of message to leave, because make sure you've got the right number, or maybe the wrong number. Maybe somebody hasn't told their family they're going into hospital or
Right,
whatever. So
privacy.
you've got to be a little bit careful what kind of message you leave. So it's getting a little bit harder to get through to families. So that's why if you could let the operator know or your physician know who's referring you in, so then they can let everybody know, then they can really make sure they contact you and get with you.
Regarding the brain monitor, does it make sense at all to have your brain monitored before you go into surgery so they know what type of brain they're dealing with?
No, because they can tell immediately.
They can,
We can
okay.
tell
I
them
thought,
to put
because
it
they
on.
didn't have a plan walking in, I just
Yeah,
didn't know.
yeah, no. Also, you'd find that difficult to get done
Yeah.
at the moment, because
Unrealistic.
it's still innovative. I mean, in an outpatient surgery center, you won't see a brain monitor.
Yeah.
It's only in major hospitals.
When you have the scan, what do you call that, scan to?
The DAD scan.
Yeah, and so they sedate you when you are having that, and that sedation, could that sedation alter the result of this, since it affects your brain activity?
The person who's doing the scan will know that, should know that, and they do know that, because that's, they've got to see the outcome is correct and right for you. So the amount that you're going to get for that shouldn't make a difference.
Because some people have a negative, and then they have another scan and it comes back positive, and you wonder.
Well, I think you're right to wonder.
Yeah.
But it should not, but
If you don't remain perfectly still.
yeah, you'll get
then
more
we may
probably.
treat it.
Yeah.
And that's what happened to me twice.
Oh, but you're sedated, aren't you?
No, I didn't get it.
No.
Actually, I took a Valium.
Oh,
No, Alan wasn't, you weren't sedated for the
are you
DAD scan.
sedated?
Does anybody have a brain, I mean, a stimulator in, a brain stimulator, deep brain stimulator in? You were talking negatively about them over there, but
One of the, our boxing patients, yeah. Yes, that's good, boxing patients.
Contenders.
Anyway, he had that put in, and we all knew him before and after. It's astonishing, the result. I mean, he now talks and drives and.
But it's absolutely vitally important that you let the hospital, the providers know that you've got that in if you're going to have surgery.
Oh.
Absolutely vital.
Oh.
They've got to turn the generator off. They've got to be careful what kind of cautery they use. They've got to make sure there's not one that would spark through the wire and hurt your brain. They've got to use what they call bipolar instead of unipolar cautery. The things that they can do, and you need to turn it off. But they can do that as long as they know.
Do you have an opinion of that procedure?
I've been involved in some. The one neurosurgeon down at Baylor does it. He does it awake, and it works well with the drugs that we use. I think the team is important there. You've got to have the same providers working together. Some neurosurgeons feel they can do a better job with the patient asleep under anesthesia, and that's, you've got to look at the outcomes to find out, you know, what which surgeon can do this and do it really well, because as you're saying, you're concerned about the outcomes of some people who've had that done. There's no doubt that if it's done right, done well, you can do much, much better with one. But it's got to be done well, and it's a very precise surgery, tricky. So you need to go somebody who's got a team that does it and does it frequently.
Don't do it unless you really need it. That's the point. The least medication and the least treatment is the best treatment. You've got to weigh what you're going to get back to the danger of going through the procedure. So if you have a slight tremor that you're looking to get rid of, deep brain stimulation is not for you. You've got to be really debilitated by it so that it's worth doing. Otherwise, you're going to run the risk of being worse when you come out than when you went in. The least treatment and the least medication is the best treatment.
So that's kind of sort of the key, is making sure there's good communication, which means that you're probably not the best communicator yourself when it's you that's going to get the procedure. You need to have, if you can, bring somebody with you who will talk for you or talk with you and make sure that they've got the list, that they've gone through everything, that everybody's aware, and that you also understand what you've been told and got that list too. Because you probably won't remember it all, and in this particular problem, good communication is absolutely necessary. You want everybody who's going to be involved in that surgery to know what needs to be done and know how to avoid complications and know how to treat them if they occur. The areas where I'd be more concerned about, not be concerned anyway, but I think, but particularly if you go for a smaller procedure as an outpatient, just make sure they understand in that surgery center that you've got Parkinson's disease and that you need to be on the medication, and make sure that the team is aware, the team's going to look after you, that you have it. There's no reason not to go to a surgery center. You know, they're good, they're great, but just make sure there's good communication.
Well, this has been so helpful. I know that I think we're all sitting here just so appreciative of all the information you've given us. And any other questions? Any other?
I just wanted to say, I was in the hospital a couple years ago for a procedure, and one problem that I noticed was with the nursing staff, and I know they're spread really thin, but trying to stick, they have their schedule for when the medication gets handed out.
Exactly.
There's the nursing staff schedule, and then there's the schedule that you're supposed to be on, and they don't usually coincide. So you have to be really assertive and say, you know, I'm supposed to take this at 6 o'clock, you know.
So that's really, again, that's part of that communication. Hopefully before you go in, or you go into an emergency, make sure the lead clinician who's looking after you, whether it's a surgeon or a medical doc, make sure they know that you're on medication and you've got to have certain signs. Yeah, and should not be stopped.
I think the nursing staff turns over so frequently that,
We've had that
you might
problem.
have told
Right.
nurse A, and then she's off and then you got nurse B, and she has no clue.
And
So-
yeah, you know, the other thing is medication errors are probably one of the biggest problems we have in healthcare still, despite dispensing machines and things like that. So you or whoever's with you should always just ask the nurse or whoever's coming in to give you medication, what is that medication?
I have one other question. My husband is at high risk for aspiration because of his throat muscles and so forth. The Parkinson is really
Absolutely,
affecting
yeah.
that. So I know you mentioned, you touched upon the aspiration risk. Do you have any, is just a matter of communicating with the doctor to let him know?
Yeah, if you communicate with the anesthesiologist, he should know that that is a problem with Parkinson's disease, and if he has to get more advanced, it should be an aspiration risk. They should know that. But as you specifically concerned about, mention it to them. That still doesn't mean you can't take your medication, you can with sip water, because that's most important to help actually obviate that aspiration risk, to try and keep you functioning better than you would if the medication was stopped.
Okay.
So it should be fun, but again, it is communication, and the more advanced or early you can communicate with the people who are going to be looking after you, the better, because then they can really be on top of their game and know, have looked back up at Parkinson's disease and the concerns with it coming through having a procedure done.
Okay, thank you. Okay, well, thank you so much for
You bet.
coming.
Well, thanks for the opportunity.